So hello again, dear friends. We will be discussing the cardiac amyloidosis. This is the second part. So the second part is actually focusing on what? It's focusing on the diagnostic pathway of cardiac amyloidosis. Of course, we discussed in the first part that cardiac amyloidosis is due to the normal transthyretin that's produced by our liver that's abnormally unstable. And those four monomers that conform the regular tetramer attached in the central part becomes unstable. And once it becomes unstable, the monomers are released into the bloodstream. And when they are released as monomers, they aggregate together to form the amyloid fibril, which is the pathology of the disease, where the amyloid fibril actually deposits in different organs. Of our interest is the heart. And we also said that there is another type of amyloid disease or amyloidosis, which is the AL type, where you have the multiple myeloma or the plasma cell tumor, where the plasma cells are crazy enough to be rapidly replicating and producing a lot of immunoglobulins in the form of light chain immunoglobulins, which are immature immunoglobulins. And those immature immunoglobulins also aggregate together to form the amyloid fibril, which deposits and produces the same clinical manifestation as the transthyretin type of amyloidosis or the ATTR. And what is important for us to detect the hematological type or the AL type is that we will refer this patient to a hematologist to get treatment. Because if this patient is not treated properly in a timely fashion, he will die within 6 months to 1 year. Our point of interest today is discussing the ATTR cardiac amyloidosis or the transthyretin type of amyloidosis. As we said, it is a grave disease. There is a poor median survival between 2 and maximum 3.5 or 4 years in the patient who are untreated. There is a misdiagnosis because if you diagnose this patient as a heart failure patient, and you start giving him the heart failure medications that improve the symptoms and signs and improve the mortality by reducing the afterload, you will find that those medications are not effective in this case because this patient has autonomic dysfunction and he's very sensitive to any kind of medication that might cause hypotension. The third thing that we discussed in the previous lecture is that we have nearly 20% of the patient that were referred to 5 different doctors before reaching a definitive diagnosis. Not only that, but also the median time for diagnosis was delayed up to 5 to 6 years. The untreated patient will develop NIHA class 3 and NIHA class 4 heart failure. And in those patients, you already have a lot of amyloid material deposited inside the patient's left ventricle and the walls of his heart. And this patient will progressively have heart failure and ultimately ending by death. So the key of this lecture is to reach an early diagnosis when this patient is still NIHA class 1 or even NIHA class 2, because this means that you do not have a lot of amyloid deposited in the left ventricle or in the heart, and in this case, the medication will stabilize the remainder of the transthyretin material within his blood, and of course, this will prevent the further deposition and further deterioration of heart failure. You can suspect the disease from a wide range of symptoms and signs, but you need to have a high index of the suspicion. If you get a patient presenting with symptoms and signs of heart failure and you do an echo and he has a preserved ejection fraction, so this is an important symptom and sign. The echocardiography will show increased LV wall thickness, but the ECG will show that this left ventricle has a low QRS voltage. And this will grab your attention. And the left ventricle is thick in cases of athletes, in cases of hypertension, in cases of WCOM. You get a thick LV, and at the same time, you get a big or long QRS complex. But in those cases of amyloidosis, you get the opposite. You get a thick left ventricle while you get a small QRS complex. Of course, the atrial fibrillation, of course, the AV blocks and conduction abnormalities. The patient is put on heart failure medications. He will deteriorate rather than improve. If you perform an echocardiography with a global longitudinal strain and you get the bullseye appearance, which we will show you later on, you will find that the apex is paired. So it colors red, which means that it's contracting properly, while the other segments are involved, which will color pale. And this means that they are not contracting properly. And this will make the apex in the center of the bullseye like a red cherry, and they call it cherry on top. Of course, with a cardiac MRI, because you have infiltrated material inside the heart, and this will take the gadolinium that is injected transvenously. In this case, the gadolinium will be attached to those materials inside the heart, and it will not be washed out. You get what is called very late gadolinium enhancement pattern, or you get what we call as failure of myocardial nulling, which means that the myocardium does not return to the null or the zero state without gadolinium, whatever you wait beside the patient and take further images across the time. As we said previously, 1 in every 6 patients referred to the aortic stenosis clinic to perform a surgical aortic valve replacement or a transcatheter aortic valve replacement may have cardiac amyloidosis and, of course, elevation of the cardiac biomarkers. We said previously that the patient might not come only to the cardiologist. He might visit the neurologist, for example, for peripheral neuropathy, for carpal tunnel syndrome, for muscle atrophy, for unexplained weight loss, for orthostatic hypotension, for sexual dysfunction, for autonomic manifestations of GIT disturbance, diarrhea, constipation, nausea, vomiting, weight loss. He may refer to the ophthalmologist for intravitreal depositions and glaucoma. He may refer to the orthopedics for biceps tendon rupture or carpal tunnel syndrome, and of course to the nephrologist for renal failure where there's deposited in the kidneys. So let's say that it is a disease with hidden manifestations because it affects many organs and many specialties can be involved, and you may not be able to catch the definitive diagnosis. So HIDDEN, it's called hidden. So you get the HFpEF, heart failure with preserved ejection fraction. You get the I for the intolerance to standard heart failure therapy. You get the D, which is the discordance between the QRS voltage on ECG and LV wall thickness on echo. You get the other D by the diagnosis of other conditions, including the carpal tunnel syndrome, lumbar spine stenosis, biceps tendon rupture. And you get the E for the echocardiography showing the HFpEF pattern and showing an increased LV wall thickness. And you're getting the N for the nervous system dysfunction, including the polyneuropathy, autonomic dysfunction, GIT disturbances with unexplained weight loss. So this is a summary. The patient has symptoms and signs which are, let's say, summarized in the beginning letter of hidden, HIDDEN. And in those cases, you can have many specialities where this patient can visit by mistake or visit in a cluster because he has a systematic disease affecting many symptoms and signs, affecting different systems. And you do the imaging technique by your echocardiography and by the global longitudinal strain and by the MRI and by the ECG, which does not appear as expected in this case of echo. So for our interest as cardiologists, when we make an ECG, we'll see the discordance between the LV thickness and the voltage. You can see the atrial fibrillation. You can see the blocks that happen in this patient, and you can see the small QRS complex of the pseudo-infarct pattern, as you see here, for example, on this ECG. You have the low voltage, you have the pseudo-infarct pattern in the infralateral leads and in the chest leads also. Echocardiography, of course, will be the next step. The echocardiography will see an increased wall thickness in the setting of an undilated left ventricle, stiff left ventricle, diastolic dysfunction detected by all the techniques, tissue Doppler, transmitral flow. The global longitudinal strain is important, and it will show you what we know as the cherry on top appearance, which we'll see in the next slide. So this is an example. Transthoracic echo showed marked thickness in the interventricular septum and in the left ventricular wall. And here you do the transmitral flow, and you see a restrictive pattern of diastolic dysfunction. And here you do the global longitudinal strain, and you detect that the apical strain is preserved, but the other walls are affected. So the central part of the bullseye is red, while the other parts are pale. And this gives you what we know as the cherry on top appearance, because it's red like a cherry on the top of a cake. And we will finish the second part of this lecture about cardiac amyloidosis about this flow chart. It's very important. As we said, you clinically see the patient, you get the red flags from the word hidden, HIDDEN, and then you have a patient with a suspected amyloidosis. As we said in the beginning of the first lecture, that you need to detect the hematological type of cardiac amyloidosis, or the AL cardiac amyloidosis, because this patient needs to be referred immediately to a hematologist to get medications. Otherwise, he will die within 6 months to 1 year. So you do a urine test and you do a blood test for AL cardiac amyloidosis, and the lab will tell you the serum kappa to lambda free chain ratio, or the serum and urine protein immunofixation detecting the monoclonal protein. If this is happening in the blood or the urine, you will refer the patient to a hematologist. He will take a medication for multiple myeloma, which is curable, do a bone marrow transplantation or whatsoever, and this patient will lead a normal life and you saved him from death. So the first step is to detect whether you need a hematologist or no. The second step, okay, he's not the AL type, he is the ATTR type. If you do get the patient as an ATTR patient after excluding the hematological form, the AL type, you will do a nuclear scintigraphy. The nuclear scintigraphy depends upon detecting of the transthyretin material that it is deposited. Okay, so you will inject a technetium, mainly technetium pyrophosphate, diphosphonates, or whatever the technetium that will be injected. The idea is that you will get an injection of a radio tracer, and this radio tracer, you need to compare what is found in the bone with what is found in the heart. So you have 4 options. Either the heart does not take the radio tracer, or the heart takes the radio tracer less than the bone, or the heart takes the radio tracer equal to the bone, or the heart takes the radio tracer more than the bone. So let's say if the heart takes the radio tracer more than the bone or equal to the bone, which we call grade 3 or grade 2, then this patient is definitely a case of cardiac amyloidosis, and you finish the flow chart. If this patient is grade 0 and he doesn't take it on the radio tracer does not go to the heart, but it goes to the bone, then this patient is not a cardiac amyloidosis. The only gray zone patient is the patient on grade 1. The heart got the radio tracer, but it is less than the bone. So this is the patient that might need a further biopsy. So you need a further biopsy only in grade 1 patient. If the patient is grade 0, grade 2, or grade 3, you reach a diagnosis. Grade 0 is out of the flow chart. Grade 2 and grade 3, he is cardiac amyloidosis, and he will continue in the flow chart. Thank you, and we'll discuss the medication available recently for these cases in part 3.